All right, so pulmonary hypertension. So this is a byproduct of patients that may have a pulmonary embolism. Pulmonary hypertension is looking at the pulmonary artery pressure and do I have an increase in the pulmonary artery pressure. So if you look here, you can see the pulmonary artery. You see the pulmonary artery. This one is squeezed down. You look at this one on this side. It is squeezed down. When we decrease the radius of a vessel, what's going to happen to my pressure? It's going up. When we decrease the size of a vessel, what happens to blood flow? So what happens to perfusion, the ability for oxygen to get into this bloodstream? Doesn't look very good, does it? So we're going to talk about pulmonary hypertension. This is another kind of mini series that's associated with the pulmonary embolism. So I think I called this, I don't even remember now. It's another little mini unit, okay? Here we go, pulmonary hypertension. So when we have pulmonary hypertension, what we're talking about is an increase in the pulmonary artery pressure. What's the normal pulmonary artery pressure? In the last lecture, I told you guys the mean pulmonary artery pressure was 15. So now we're going to kind of take that and we're going to extend it a little bit. We're going to create a range. A normal range for a pulmonary artery pressure is 10 to 20. Normal pulmonary artery pressure is 10 to 20. And anytime that we have a pulmonary artery pressure that's greater than 25, a pulmonary artery pressure that's greater than 25, we're going to call that pulmonary hypertension. We see this a lot with chronic pulmonary disease, or what's a mainstay chronic pulmonary disease that we take care of day in and day out? COPD. Why is it that COPDers have chronic pulmonary disease? Well, they live in a chronic hypoventilation state. They chronically live with respiratory failure. So what does that mean? That means that their CO2 is greater than 50 and their pH is within the normal limits. It's in the acidotic side of the normal limits. And what does their oxygenation look like? Their oxygenation is poor, right? So we've got the decreased pH, we got the increased CO2, and we've got the decreased O2. All three of those will increase pulmonary vascular resistance. If I increase pulmonary vascular resistance, the vessels are getting smaller. Just like that picture that we saw in the previous overview slide. The next thing is women are 3 times more likely to have pulmonary hypertension than guys. I don't know what to say. I don't know. Ladies, you guys missed it on this one. I don't know what it is. I don't know why it is, but it is more likely that females will have pulmonary hypertension 3 times more likely. For every 1 guy that has pulmonary hypertension, there's 3 females that do. Signs and symptoms that we see with pulmonary hypertension, dyspnea with activity. Dyspnea with activity. That lightheadedness, dizzy, confusion, all of those things are from a decrease of blood flow to the brain. If I'm not getting it from the right side of the heart, I'm not to the left side of the heart, then I have less blood flow coming out of the left side of the heart going up to the brain. Lightheadedness, dizzy, confusion. Fatigue. You don't have blood circulating as well as it should be. You're not going to be moving as effectively as you could. Non-productive cough. This could be from the irritant response with the pulmonary capillaries opening and allowing red blood cells into the alveoli. Now you get red blood cells into the alveoli and you have blood in the lungs, hemoptysis. Hoarseness, syncope. Your syncope comes into play here with your lightheadedness and dizziness. Chest pain, decreased expansion, racing heart rate, upper right quadrant abdominal pain. What's in that upper right quadrant? What is it? What's the organ that's on the right side? If you said liver, you're right. If you had blood that cannot get through the pulmonary arteries, it's going to back up into the right ventricle. From the right ventricle, it's going to go into the right atrium. From the right atrium, it's going to go into the superior and inferior vena cava. So whenever I look at the superior vena cava, I'm going to get JVD. When I look at the inferior vena cava, I'm going to have a swollen liver or hepatomegaly, which can lead to right upper quadrant abdominal pain. You're going to see abdominal fluid. You're going to see a decrease in appetite. You're going to have edema. Oh, hepatomegaly right there. They're side by side. And Raynaud's phenomenon. This is a peripheral vascular disease that has poor circulation out in the digits. So you can get blanching of the fingers with cold exposure by itself. They don't have to have any sort of pressure that's associated with it. So Raynaud's phenomenon, this is a pulmonary vascular disease that we can see that is associated with pulmonary hypertension. When we look at diagnostics, we're going to look at an echo, chest x-ray, EKG, right heart cath, and high resolution CT. So with an echo, I'll be able to see, and the echo will show the size and the thickness of the right atrium and the right ventricle. And if there's any sort of tricuspid regurgitation. And we can actually look at the echo and we'll be able to estimate the pulmonary artery pressure. Now, I've used ultrasound quite a bit, but when it comes to measuring these pressures, that's a little out of my scope. However, it is something that we could definitely learn and we can take on so that we can identify this even faster, perhaps if radiology is not available right in that moment. So it's something that we can definitely develop. It's something that we can get stronger with when it comes to these echocardiograms. When we look at a chest x-ray, we're going to see the right ventricle and pulmonary artery enlargement. This typically we will see with underlying lung disease like COPD. EKG, rhythm is steady or irregular. You're going to have a right axis deviation, right ventricle hypertrophy, and ventricular strain. When we go through our EKG course, these things will make a whole lot more sense. Okay, right now I want you to understand the terminology that with pulmonary hypertension, you're going to have either a regular rhythm or an irregular rhythm. Right axis deviation, right ventricular hypertrophy, and ventricular strain. So understand that those terms are associated or linked to pulmonary hypertension. When we do a right heart cath, this will actually confirm our diagnosis or our hunch or our thought that this patient has pulmonary hypertension. We can evaluate any of the hemodynamic damage that's taken place, and we can restore. We can do some vasoreactivity test to not necessarily restore, but we can identify how much damage has been done, and we can give the patient a true prognosis as to what to expect moving forward. And then the high resolution CT, this is to rule out underlying causes or conditions, because you could have a patient with, I don't know, any condition that can cause ventilatory failure, both type 1 and type 2, can create an increase in the pulmonary vascular resistance. Well, if we have that increase in pulmonary vascular resistance, we're going to have the likelihood that the patient will have pulmonary hypertension. But this will help us, these CTs will help us rule out any other conditions that we could be or we could see that are associated with pulmonary hypertension. Other diagnostics that we could look at is an MRI. We could do an MRI of the chest to help detect any of the signs or rule out underlying conditions. This will actually show us the right ventricle function and blood flow to the lungs. We can use a PFT to rule out any significant restrictive lung disease and obstructive lung disease. And with our DLCO, the diffusion capacity of our lungs for carbon monoxide, this will be decreased with idiopathic pulmonary hypertension. So we're going to use a PFT to rule out any of these other restrictive or obstructive lung disease. And we can look at the DLCO, which is the diffusion capacity of the lungs for carbon monoxide. And we'll talk about full-blown PFTs here shortly. But when we look at the DLCO, it's the diffusion capacity of the lungs for carbon monoxide. we would see this decreased with idiopathic or from an unknown origin pulmonary hypertension. We could do a sleep study. This is our first time to see a sleep study. Another name for a sleep study is polysomnography. Polysomnography. And this we would definitely look at to identify and determine if apneas or hypoxias during sleep are the cause of that pulmonary hypertension. We can look at the VQ scan, and probably more so we're going to look at the CTA, since that's becoming way more prevalent than looking at the VQ scan. And then hematology, we're going to rule out HIV, liver disease, or any autoimmune diseases like rheumatoid arthritis that could be causing the pulmonary hypertension. When we look at pulmonary hypertension, we have four different classes of pulmonary hypertension. One is the most mild or the most benign, to a 4 that is the most severe. So when we look at the classes, the lower the class 1, the least severe the symptoms and the identification. So patients can perform regular physical activities without symptoms. When we start moving into class 2, we get slight or mild limits. So patient is comfortable while resting, but regular activities causes symptoms like the shortness of breath and the signs and symptoms that we saw a couple of slides ago. Class 3 is noticeable limits. They're comfortable while resting. Regular activities cause symptoms. Very similar to class 2, but we've got noticeable limits. We've got noticeable limits compared to the slight or mild limits. And then the last one is severe and marked limits. Symptoms may present at rest, unable to perform regular physical activity without discomfort. So we see you even get symptoms when you're at rest when it comes to a class 4. When we look at right-sided heart failure, this right-sided heart failure, it's going to cause shortness of breath. You'll get that irregular fast heart rate, JVD, peripheral edema, hepatomegaly, abdominal distension, abdominal pain. It could lead to a decrease in appetite or having anorexia, nausea, fatigue, weakness, and faintness. This is all from a decreased amount of blood flow coming out of the left heart. And then your weight gain comes from all the additional fluid from the peripheral edema. So you got no desire to eat and you're nauseous, yet you still gain weight from all the peripheral edema that is accumulating. We have left-sided heart failure. You have shortness of breath. You have lightheadedness and or faint, pink frothy sputum. You have a cough, orthopnea, paroxysmal nocturnal dyspnea, or whenever you start to lay down to go to sleep. When you start to lay down to go to sleep, you have shortness of breath or dyspnea, weak pulses, hypotension, decreased urine production, activity intolerance, cyanosis, cool and clammy skin. So when we have left-sided heart failure causing the backup from the left side of the heart backing up into the lungs, backing up into the right heart, these are our symptoms. When it comes to right-sided failure only, that's the previous slide. What we call right-sided heart failure only is cor pulmonale. What we call left-sided heart failure is congestive heart failure. So differentiating between the right and the left. When we come to management, there is no cure. There is no cure for pulmonary hypertension. You have to treat the symptoms. You have to take care of what you are seeing as far as signs and symptoms. We want to use diuretics to get rid of all of that extra fluid. It reduces any of that fluid buildup. When we look at the phosphodiesterase inhibitors, these are what will cause vascular relaxation. These are medications that end with FILS. So look for those medications that end with FILS. Those are phosphodiesterase inhibitors. You can have patients that are on blood thinners because the less viscous that blood is, the more blood it can get through and the less pressure that you will have. You could be on cardiac glycosides like digoxin or what we just call DIG, and this will help the heart pump stronger. We're talking about a lot of these medications this summer, but just go ahead and start writing these down. Spend some time looking them up, getting familiar with them, because they are going to come back up in the future. You want patients on oxygen therapy, because oxygen will dilate. That will dilate the pulmonary artery. You want to see what you can do with physical activity without pushing yourself too hard. And then inhaled nitric oxide. This is the only FDA approved treatment for nitric oxide, so pulmonary hypertension. So nitric oxide. And the thing with nitric is if it doesn't fix it in the first 24 hours, most likely it's not going to fix it down the line. So we just want to be aware of nitric oxide and our utilization of it with our patients. When it comes to us as respiratory therapists, we have to first recognize signs and symptoms. When you have patients that are presenting with any of those signs and symptoms, whether it's right heart failure or left-sided heart failure, we need to be the ones to communicate to the team very, very effectively. We want to make sure that we are gathering all the information that we can with the patient's health history, with our IPPA, with our patient interview. All of those components come into play right here. We're going to use inhaled gases like oxygen and nitric oxide, and we can even aerosolize some medications as well. So that's what we're looking at when it comes to our role. This down here, this phassociation.org, this phassociation.org is a fantastic resource. It's a fantastic resource to find any additional information that you could possibly want when it comes to pulmonary hypertension. I highly recommend you guys going around and just navigating this website whenever you have some time. It will change how well you understand and what you know about pulmonary hypertension. So that's what we've got when it comes to pulmonary emboli and pulmonary hypertension. Those two go hand in hand, and we'll see that we utilize our assessment skills for both of these. From those assessment skills, we want to make sure that we are communicating effectively to the team to make sure that everybody that's part of the care team knows what's going on with the patient, and we are being thorough with our assessments so that we can get the right treatment, the right diagnostics, and take care of the patient as effectively as we possibly can. So that's what you've got when it comes to taking care of pulmonary emboli and pulmonary hypertension.